A 34-year-old woman presents with mild dysphagia and an incidental mediastinal mass found on a recent chest radiograph. I am showing you a contrast-enhanced CT of the chest. Describe the findings.
Okay. The CT demonstrates a smoothly marginated, homogeneous fluid-attenuation cystic mass in the posterior mediastinum. The mass is inseparable from the distal esophageal wall and causes extrinsic mass effect, deviating the esophageal lumen. There is no internal enhancement or solid component.
What is your primary diagnosis?
The primary diagnosis is a foregut duplication cyst, specifically an esophageal duplication cyst, given its intimate association with the esophageal wall.
What are the three main types of foregut duplication cysts found in the mediastinum, and how are they differentiated embryologically?
The three types are bronchogenic cysts, esophageal duplication cysts, and neurenteric cysts. They arise from abnormal budding of the primitive foregut. Neurenteric cysts are specifically associated with vertebral anomalies, like hemivertebrae, due to incomplete separation from the notochord.
What imaging modality is considered the gold standard for characterizing the wall of an esophageal duplication cyst, and what is the classic finding?
Well, endoscopic ultrasound is the gold standard. The classic finding is the double wall sign, or gut signature, which consists of an inner echogenic mucosal layer and an outer hypoechoic muscular layer, confirming its enteric origin.
If this cystic mass demonstrated high T1 signal intensity on a subsequent MRI, what would be the most likely causes?
High T1 signal intensity within the cyst would suggest either prior intracystic hemorrhage or highly proteinaceous mucinous fluid contents.
Why must you carefully evaluate the spine on imaging when a posterior mediastinal cystic mass is identified?
Well, to rule out a neurenteric cyst. Identifying vertebral anomalies, such as butterfly vertebrae or spina bifida, confirms a neurenteric origin, which may have an intraspinal extension requiring neurosurgical evaluation.
What are the potential complications of an untreated esophageal duplication cyst?
Potential complications include progressive dysphagia from mass effect, intracystic hemorrhage, infection leading to abscess formation, and, rarely, malignant transformation into squamous cell carcinoma or adenocarcinoma.
How would you manage this patient as a radiologist?
I would communicate the findings to the referring clinician and recommend presenting the case at the thoracic multidisciplinary team meeting. Given the patient is symptomatic, we would discuss surgical excision versus referring to gastroenterology for endoscopic ultrasound evaluation.